Okay, welcome back, committee. We now are going to switch topics and we're moving to overdose prevention. I didn't want any grass to be growing underneath our feet since we passed out a bill yesterday. We have a new one today, and that's H222. And to be fair, I think that, to be honest, we are going to take a look at three bills that are in that little corner, not today, but 112, 241, and 222 that all relate to the same topic. We have had a request to move 241 downstairs to housing, but I read the bill and I don't think so. It didn't come from the chair of the committee.
Recovery residences?
Yeah,
Okay.
it's very treatment oriented. The bill is, it's got some of the same stuff that you have in your building, but I think it's where it belongs is here. 222, and just to shout out to Recovery Day, that thank you for making mention of that for our committee, Dane, and I'll turn the floor over to you, Ms. McLean.
Thank you. Katie McLean, Office of Legislative Counsel. I will share my screen. I think. Okay. So H222. You may find, if you were on this committee, serving on this committee last year, that some of these provisions are similar to H728 that this committee worked on last year. So if I can remember, I'll try to flag similar sections as we go through. So we have a long statement of purpose, and we don't get to the actual substance until page 3. And last year you worked on language with regard to unused prescription drug disposal programs. And this adds the disposal of syringe into these programs. So the Department of Health shall establish and maintain the statewide unused prescription drug and syringe disposal program to provide for the safe disposal of Vermont residents' unused and unwanted prescription drugs and syringes. The program may include establishing secure collection disposal sites and providing medication envelopes for sending unused prescription drugs to an unauthorized collection facility for destruction. Subsection B, this is a new addition, and I should say, were the committee to move forward with this, I would pull this paragraph out and put it in session law. It's a one-time appropriation and it shouldn't be embedded there. But the substance is that in fiscal year 24, $325,000 is appropriated from the general fund to the Department of Health's Division of Substance Use Programs.
Oh, it says Heath.
Oh, you're right. Oh my goodness. We have to hire you as one of our editors.
Not really. Easy miss because your eyes just shoot
right over it.
The Department of Health's Division of Substance Use Programs to provide grants and consultations for municipalities, hospitals, community health centers, and other community syringe disposal programs available to the public. And then in subsection C, we're adding a effective date for the syringe disposal. So the prescription drug disposal kiosk is to take effect on or before July 1 of 2023, and adding the syringe disposal kiosk would be July 1, 2024. Okay. And then language specifying that the mail-back option is for prescription drugs. And then we have syringes. Yeah, no syringes. Yeah. The next piece is on opioid antagonists. So this is amending existing law. We have a series of definitions about who a healthcare professional is, what an opioid antagonist is. In the existing law, there is the phrase victim, and the proposal is to change it to survivor, meaning the person who has overdosed on an opioid or who is believed to have overdosed on an opioid. And then in subsection B, we have language that for the purpose of addressing prescription and non-prescription opioid overdoses in Vermont, the department shall develop and implement a prevention, intervention, and response strategy depending on available resources that shall. There's some changes here. So to provide educational materials on opioid overdose prevention to the public free of charge, Removing language including to substance abuse treatment providers, healthcare providers, opioid users, and family members of opioid users. Subdivision 2 stays the same. Subdivision 3, increase timely access to treatment services for opioid users, medication for including medication for opioid use disorder. In subdivision 4, removing the first subdivision, educate substance abuse treatment providers on methods to prevent opioid overdoses. And leaving the second subdivision, provide education and training on overdose prevention, intervention, and response to individuals living with opioid addiction and participating in opioid treatment programs, syringe exchange programs, residential drug treatment programs, or correctional services. In subdivision 5, removing facilitate overdose prevention drug treatment and addiction recovery services by implementing and expanding. And instead it would start with implement and expand hospital referral services for individuals treated for an opioid overdose. Subdivision 6, we're replacing the phrase individuals with a history of opioid use, and instead it would be individuals with opioid use disorder.
And deleted pilot.
Oh, that's important. Yes, thank you. And deleted pilot. Adding 2 new subdivisions at the top of page 6, distribute opioid antagonists to entities in a position to assist those at risk of experiencing an opioid-related overdose, and establish opioid antagonist dispensing kiosks in locations accessible to those at risk of experiencing an opioid-related overdose. In subdivision C1, the healthcare professional acting in good faith and within the professional scope of practice may directly or by standing order prescribe, dispense, and distribute an opioid antagonist to the following persons. And that list is the same. What you're removing is provided the person has been educated about opioid-related overdose prevention and treatment in a manner approved by the department. Subdivision 2, we do not have any changes, so I'll move past that. Subsection D, subdivision 1. So this is where we see that swap out of the term victim for survivor. A person may administer an opioid antagonist to a survivor if the person believes in good faith that the survivor is experiencing an opioid-related overdose. In subdivision 2, we are replacing he or she with the person. Subdivision 3, again, we have that spot of victim for survivor. A person shall be immune from civil liability for administering an opioid antagonist to a survivor. Subsection E has not been changed. Subsection F, if any healthcare professional who treats a survivor and who has knowledge of the that the survivor has been administered an opioid antagonist within the preceding 30 days shall refer the survivor to professional substance abuse treatment services. I'm only pausing there because I'm thinking through substance abuse treatment services, and I wonder if that would be substance use disorder services now. Yep. Okay. Operation of syringe service programs. This is a piece of language that the committee looked at last year. So this expands or carves out from the definition of drug paraphernalia other harm reduction supplies. So this exempts other harm reduction supplies from a penalty for selling drug paraphernalia to a minor. Let's see. Section 4 prohibits testing for adverse reactions prior to prescribing medications to treat opioid use disorder. So we have this existing language. The rule shall include the following requirements. One of the existing requirements in subdivision B2 is that a medical assessment shall be conducted to determine whether a pharmacological treatment, which may include methadone, buprenorphine, and other federally approved medications to treat opioid addiction, is medically appropriate. And the new language would read, a medical assessment shall not require a patient to consume medications either through a MedWatch, FDA Form 350 or 3500, or otherwise, in order to verify allergic or otherwise adverse reactions to medications. Next, we have prior authorization for MAT medications for Medicaid beneficiaries. On subsection A, we have a requirement to cover, requires coverage to Medicaid beneficiaries for medically necessary MAT prescribed by a healthcare professional who's practicing within the professional's license and participating in the Medicaid program. And secondly, in subdivision B, we have language that pending the approval of the Drug Utilization Review Board, the agency, meaning AHS, shall cover at least one medication from each therapeutic class for methadone, buprenorphine, naltrexone as listed on Medicaid's preferred drug list without requiring prior authorization.
People might recall we had
A lot.
quite a lot of testimony about that last year. And I
Let's try.
expect we will again.
Try.
Okay. So the next piece has to do with recovery residences. In fact, this concept, it comes from the bill we were just referencing, H241. And this is language that has to do with zoning. It requires a municipality to treat a recovery residence as a single family home under land use bylaws. So we have language here that the following land development provisions shall apply to every municipality. There has to be equal treatment of housing and required provisions for affordable housing. And under that subdivision, a residential care home or group home to be operated under state licensing or registration, serving not more than 8 persons who have a disability, and adding in a recovery residence serving not more than 8 persons shall be considered a right to constitute a permitted single-family residential use of property. I'm going to pause here because this section was literally pulled out of another draft and taken out of context. So the definition of recovery residence is defined in H241, but it is not defined. The cross-reference is meaningless here. So I will stop sharing and I'll flip documents quickly. Here we go. Okay. So here we go. This is the definition of recovery. Have it now. The recovery residence definition as used in another bill, but not enacted. As used in this section, recovery residence means a shared living residence supporting persons recovering from a substance use disorder that provides tenants with peer support, an environment that prohibits the use of alcohol and the illegal use of prescription drugs or other illegal substances, and provides assistance, accessing support services and community resources available to persons recovering from substance use disorders. And secondly, is certified by an organization that is a Vermont affiliate of the National Alliance for Recovery Residences or obtains a preliminary certification within 45 days of operation and adheres to the national standards established by the Alliance or its successor in interest, including duty of care standards. If there is no successor in interest, the Department of Health shall designate a certifying organization to uphold appropriate standards for recovery housing.
And that this, members, is also a definition contained in H241. It's the same definition. So it's one of the reasons why I think we need to kind of look at all 3 of these bills together.
Okay, I'm switching back to the original document.
H222, 112, and 241.
Okay, so final page of the bill. The second to last section removes the future repeal of the buprenorphine exemption that I believe you worked on last year with Michelle. So that is the repeal, and then we have effective dates. The act takes effect on passage, with the exception that section 5, which was the MAT medications section, wouldn't take effect until September 1st, 2023.
Thank you. Anybody have any sort of questions of, I'm going to put Representative Whitman on the spot as well, just because this is his bill and we didn't really have the chance for you to kind of like do your 5-minute why we should take up the bill because we already decided to take up the bill. So you have anything you want to add to the work that you've done to bring this forward?
Yeah, no, definitely. Thank you. Really happy to be walking through the bill right now. Yeah, clearly it's sort of a culmination of the past 2 years of work that we've seen as far as bills that were on our wall last biennium, bills that we worked on during session and ultimately didn't make it through. And so revisiting a lot of those concepts with the understanding that there's some degree of urgency for some policy to get through to start addressing these issues, just with the ongoing state of the overdose crisis that we're working with. I do want to acknowledge that, a lot of this was things that I worked on based off of other statute that has been introduced, and so have the full recognition that, like me, it is imperfect. All of the language up there, and really want to, just like we just did with the markup for H-171, that this is really no longer my bill, it's the committee's bill, and really just look forward to all of your engagement and input and questions as we sort of shape this to help our communities.
Great, Representative.
I just have a question out of curiosity. So, I don't know what page it is, 9. So on section 2, so it's line 7 through 12, the part about verifying allergic reaction, just kind of curious where that came from and like why, what other ways you would verify it? You're not sending somebody off who's going to have an allergic reaction.
Right. So the key word within this is require. And the idea is that we received testimony last year from a provider that maybe we can have revisit, who talked about a process by which somebody wanting an alternative medication, if they said, hey, I'm allergic to this, it was required that they would take the medication in front of the provider.
And get sick.
And have their
And watch them have a
So this is the,
even if they already knew they were allergic, they had to
Okay,
prove
so
it
that
with a
way,
doctor.
okay.
the intention is to not necessarily say you can't test for an allergic reaction. It's saying that you can't require a patient to do this process by which you take something.
Right.
They're asking.
I got you.
Don't worry, we have our, what's the medication there? Right handy.
No.
Right.
Yeah.
EpiPen?
Yeah, we have your EpiPen right here. There's nothing to worry about.
Experience, but yeah.
Yeah,
I got
we were like,
Stuff that makes
seemed like, doctor needs to make somebody sick in order to make them well. That didn't make sense. Okay.
Thank you for that.
Yeah, thank you.
Any other sort of clarifying questions that people might have for this? And as I said, I would like us to even sort of maybe expand our testimony a bit beyond the things that are in this bill. And so we'll be taking this up over the next couple of weeks, and we will, I'm just thinking, Katie, about we'll schedule a walkthrough of 112 and 241 as well. Just so people have us, and probably if we get another one between now and when we take action on a bill, I want us to think comprehensively, but I also want us to be responsive to things that might be more controversial, but I don't want us to necessarily steer away from them either. So I want us to take a comprehensive look. Yeah. Representative Gregoire.
Why, thank you, Madam Chair. The other question I had, I'm sure you're way on top of this. So we're going to hear from entities, I assume, that would be affected by the required kiosks.
Yes, we will. We're going to, some of these things were in last year's, we considered last year. So we'll pull up some of the people that we had last year. We'll add to them as well. The addition of the syringe is new. So, we'll obviously ask about the questions about that. And that's why we ended up, I don't know if you might recall, why we ended up with that 10 or more, because we were really dealing with national chains that have provisions for these. So yeah, the answer is yes. Sorry, that was a long answer
Okay.
to what could have been something short. The answer is yes. Yeah, go ahead.
For anyone who happens to be curious, you can ask me later about that last section on zoning is what's in front of the Vermont Supreme Court right now over the Newbury. The definition in that is what's being contested. So.
Yeah, and I just because I've been around for a while, and that definition came from group homes for people with disabilities, and sort of the not in my backyard kind of sense about that, and so that was really landmark legislation, 1990s, maybe
It
80s,
started
maybe,
with,
I don't know, might
I
have
think
to go
it
back.
started with developmental disabilities
did.
and then was expanded to, in terms of disability to include people with psychiatric
Yeah.
and mental health.
It was, it made a big difference. It doesn't mean that you don't take into consideration the neighbors or the neighborhood because you want something to be appropriate, but it's, yeah, anyways, it has a long history. Yeah,
I'll just speak to that really quickly, is that the definition of disability that current statute has does include people with substance use disorder. The key part is that it's licensed or accredited by the state, and currently the Department of Health does not license
these.
recovery houses. So this is creating the definition of recovery houses that are certified by VTAR, which is the current practice. So that's just, it's finding its way into the statute.
So it's really not making a substantive change in a lot of
No.
ways because it was, the type of facility is already covered. It's a licensing technicality.
it is, but I have to say, it brings up for me the question about whether, not the health department per se, but whether licensing and protection should be adding that as a category of, it's a rhetorical question right now, but because it is, I forgot what the number is, but X number of or more of unrelated individuals living in a common space for a common purpose.
Oh, that's right.
It could be interpreted that perhaps APS should be or might in the future. In any event, that's it for today. We're going to be on the floor in just a few minutes. Thank you, Katie. Appreciate that. And
1.5 to be specific.
tomorrow morning, we're back at it at 171. So we'll be fresh in the morning, right?